Geer, and I put this presentation together with my partner, Dr. Jeff Sachs. We're both neuroradiologists here, and this is a 1-hour video session on approach to head CT and brain MRI, just to get you started. Some of this you all already know, some of it will be review, and some of it will be new, and I hope to package some of it together for you as you are doing your neurology clinical rotation. Just as a reminder, CT is, you will put the patient on a table. We have an X-ray source that rotates around the patient, and the X-ray goes through the tissues and is variably absorbed by the tissues. Some of the X-ray goes through to these detectors, and the amount of X-ray that goes through to the detectors determines the grayscale appearance of tissues on CT imaging. So when you're doing a CT scan, you are delivering some radiation that is absorbed by the tissues. If most of the X-ray gets through the tissues to the detector, like would be in the lungs, because the lungs are air, then that tissue appears very dark on CT or black. If most of the X-ray does not get through the tissue to the detector, like the skull blocks most of the X-ray, then that tissue, the skull, would be dense or white appearing, and we'll look at more of that. It doesn't take long to do CT. A head CT, once you get the patient on the table, takes about 5 seconds to do. We're going to image the patient once, and then we're going to take that data and we can apply different post-processing algorithms to the data to give you axial planes, sagittal planes, coronal planes. When we're looking at head CT, we are talking about structures in terms of density. So structures such as the ventricles that are dark or black, we don't say they're black, we say they're low density. They're low density because most of the X-ray went through the CSF and got to the detectors. This skull is hyperdense. It is white, but we're doctors, so we're not going to say it's white. We're going to say it's high in density or hyperdense. You can also say high or low attenuation, meaning attenuation of the X-ray beam. But when you're talking about something on CT, you want to talk about it in terms of its density. Is it high density, intermediate density, or low density? When you're looking at a CT scan of the head, we're going to always give you 2 windows. Windows is a technique we use to enhance the contrast of certain tissues. We're going to give you a brain or soft tissue window, and we're going to give you a bone window. Again, we've scanned the patient once. We put a different algorithm, post-processing algorithm, on the study to give you the brain window and the bone window. The bone window is nice because it gives you a nice sharp edges of the bone, helps us find non-displaced skull fractures and osseous destructive lesions. This is what happens if we put the bone post-processing algorithm on the brain. You can see this brain looks very grainy compared to this brain. We'd much rather look at this brain. It's more pleasing to the eye as opposed to this brain where we put the bone algorithm on it. So again, you're going to always want to look at both the soft tissue brain window and your bone window. Those will both come in an axial plane. Let's review quickly some anatomy that becomes important when looking at CT. Again, you always know it's a CT scan and not an MRI because you're going to see this hyperdense skull on CT. MRI does not have that. So if someone pulled this up, you would automatically say this was a CT and not an MRI. Down we're here at the foramen magnum, and here you're going to see we have the medulla right here at the foramen magnum. As we're slicing going from inferior to superior, here we have the pons more superior to the medulla with the bilateral middle cerebellar peduncles. Here we have the 2 cerebellar hemispheres. We're going to go more superiorly. We're at the level of the midbrain where we have our 2 cerebral peduncles of the midbrain. If we go higher up, you're going to see nice gray and white matter differentiation. Notice that white matter is lower in density than gray matter. On every case, you want to find this cut in the middle of the brain where you can see the frontal horns of the lateral ventricles. And you want to see these two white matter tracts. Notice that they're low density. This is the anterior and posterior limb of the internal capsule. When you find that, if you go medial to the posterior limb of the internal capsule, you will have the thalamus that's on either side of the third ventricle. If you go lateral to the posterior limb of the internal capsule, you have the basal ganglia, the globus pallidus that's medial, the putamen that's lateral. You can't really differentiate these two very well in CT, but you can on MRI because on MRI the resolution is better. If you go medial to the anterior limb of the internal capsule, you have the caudate head of the caudate nucleus. Again, remember the thalamus is on either side of the third ventricle. It's supplied by the posterior circulation. The basal ganglia are predominantly supplied by the anterior circulation. When you go higher up, you always want to make sure I see good gray and white matter differentiation. Notice again, the white matter is lower in density than gray matter. You're always going to look at the frontal lobes, the parietal lobes, the temporal lobes, and the occipital lobes. One of the things you always want to look for are the basal cisterns. Those are the CSF spaces at the base of the brain. And this basal cistern is a very important one. It's located just above the sella, just above the pituitary gland, and this is called the suprasellar cistern. It's a CSF space right there at the base of the brain, feeds into the sylvian cisterns and fissures on either side. Remember that the circle of Willis lives in the suprasellar cistern. The middle cerebral arteries go out in the sylvian fissures. And when patients have a ruptured aneurysm of the circle of Willis, you're going to see acute subarachnoid hemorrhage here in that suprasellar cistern. There are CSF spaces or cisterns that surround the brainstem. The one that's posterior to the midbrain is the quadrigeminal plate cistern. The cisterns that are around the midbrain are on either side are the ambient cisterns. Remember the anatomy of the ventricles. You have the frontal horns of the lateral ventricles, the body of the lateral ventricles, you have the occipital horns of the lateral ventricles, and in the temporal lobes, remember, you have the temporal horns of the lateral ventricles. Remember that the temporal horns should be small. This is what normal temporal horns look like. They're small. Early hydrocephalus, you're going to get enlargement of the temporal horns. You will also get rounding of the third ventricle. Remember that the third ventricle should be linear or slit-shaped in normal young people. The CSF drains from the lateral ventricles through the foramen of Monro into the third ventricle, from the third ventricle through the cerebral aqueduct and into the fourth ventricle. Let's move on to talk about common pathology. If you see an abnormality in the brain or intracranially, you want to determine, is that abnormality, such as a hemorrhage, is it intraparenchymal, meaning in the brain itself? Is it subarachnoid, meaning in the CSF spaces around the brain? Is it subdural, between the dura and the surface of the brain? Is it epidural, between the dura and the calvarium? Or is it intraventricular? Remember that CT is really best for evaluating for the presence of acute hemorrhage, hydrocephalus. It's of course also good for mass effect and herniation, some other things, but we're going to always get CT first if someone has an acute neurologic change, because one of the big things we're looking for is acute hemorrhage, something that could cause a patient to deteriorate very quickly if we didn't know about it. Acute hemorrhage in the brain is increased density. It looks kind of white. Of course, we're not going to say white. That'd be a layperson's term. We're going to say it's hyperdense or high density. You can also say increased attenuation if you prefer that. If you see an area in the brain that's low density and has some mass effect, that's usually going to be edema, and we'll talk about that. So this was a patient, this was a 70-year-old who presented with sudden onset left-sided weakness, we're always going to get a head CT without contrast first because we're worried about, acute hemorrhage. And here we have this area of hyperdensity. It's centered in the right basal ganglia. This would be compatible with an acute right basal ganglia hemorrhage. Again, this is what hemorrhage looks like. It's hyperdense, not quite as dense as calcium, like in the calvarium. This is a different patient. This is an 80-year-old female who presented with sudden onset left-sided weakness. So, of course, we get the head CT without contrast. And here we see this focal area of hyperdensity. It's intraparenchymal. It's centered in the thalamus and involves also this white matter tract next to the thalamus, the posterior limb of the internal capsule. So here we have an acute right thalamic hemorrhage that involves the posterior limb of the internal capsule. Both of these were examples of what we call hypertensive hemorrhages. These are hemorrhages that occur in classically these four sites: the basal ganglia, the thalamus, the brainstem, especially the pons, and in the cerebellum. These hemorrhages can be large, like in this basal ganglia hemorrhage, or they can be smaller, like this thalamic hemorrhage. And again, they're typically seen in patients that do have a history of hypertension. If I saw a hemorrhage in the left frontal lobe, I wouldn't jump on that as hypertensive likely, even if the patient had a history of hypertension. Hypertensive hemorrhages typically occur in what I call the big four: the basal ganglia, the thalamus, the brainstem, and the cerebellum. This is a 14-year-old who presented was sitting on a couch and all of a sudden laid down on the couch and had a seizure. They brought her in. She got a head CT without IV contrast because she had a new neurologic deficit. And here we have an area of hyperdensity centered in the left thalamus, centered in the left parietal lobe. I apologize for that, misspoke. This is an area of hyperdensity centered in the left parietal lobe and extending into the left lateral ventricle. This is compatible with an acute left parietal intraparenchymal hemorrhage with intraventricular extension. Notice there's a little bit of low density surrounding this hemorrhage. This is consistent with edema. So this is a 14-year-old. So we wouldn't think this would be hypertensive necessarily in etiology. It's also not in one of the big four. It's not in the basal ganglia, the thalamus, the brainstem, or the cerebellum. So we have to think of other causes of hemorrhage. We have no history of trauma, so we don't think this is traumatic. And this brings up a great differential for the etiology of intraparenchymal hemorrhages. Hypertension being one, we just talked about that. Trauma, and usually you'll have a history of that. Arteriovenous malformation, or AVM, that is what this case is. This was a ruptured AVM. And remember what an AVM is. It's an area of the brain where the capillary bed failed to form. These are usually congenital lesions, although they can evolve over time, and you have basically a direct connection between arteries and veins without an intervening capillary bed, and over time those can rupture and typically give you a parenchymal hemorrhage. If I see an acute parenchymal hemorrhage in a young person or child, a ruptured AVM is going to be high on my list. You can also get hemorrhagic transformation of ischemic infarct. For instance, if you have an occluded left middle cerebral artery, you get an ischemic infarct. The vessels supplying that infarct are also sick and they can bleed, and you can get hemorrhage into an ischemic infarct. Remember that infarcts can be arterial in etiology, such as an occluded middle cerebral artery, but they can also be venous in etiology, such as in patients with dural venous sinus thrombosis. You can get hemorrhage from an underlying mass. You can get hemorrhage in older patients from amyloid angiopathy. That's typically in patients that are over 65 or 70 years old. And of course, patients who have a coagulopathy, maybe a hematology oncology patient who is thrombocytopenic, or someone who has an elevated INR or liver failure can have hemorrhages. This is a 50-year-old female who presented with progressive headaches over a day and a half, no history of trauma. She gets a head CT without contrast, and here you can see these areas of hyperdensity compatible with acute hemorrhage with surrounding low-density edema. So we've got an acute right temporal hemorrhage and edema. So we're going to go through our differential. This could be hemorrhage into a tumor, could be hemorrhagic transformation of an infarct. It's a lot of edema for an AVM. It's not in a good place for a hypertensive hemorrhage. She's only 50, so we don't think it's amyloid, and this turned out to be hemorrhagic conversion of a venous infarct. It's a different patient. This was a 40-year-old who presented with sudden onset headache and dizziness. He gets a head CT, which shows this focal area of hyperdensity in the right cerebellum, compatible with an acute hemorrhage. So we're going to go, there was no trauma. So this could be a hypertensive hemorrhage. It's in the cerebellum, which is in one of the big four for hypertensive hemorrhages. However, he's a marathon runner with a blood pressure of 110 and no history of hypertension. So let's think of other things. It could be hemorrhage into a tumor. It could be hemorrhage of a ruptured AVM. Could be hemorrhagic conversion of an infarct, although not the right history for that. So we have AVM still on our differential. One of the non-invasive ways to look for an arteriovenous malformation is to perform a CT angiogram. How do we do CTAs? Well, we're going to put in a large bore IV, inject contrast, and we're going to image the neck and head so that we're imaging the carotid vertebral arteries and the intracranial arteries at a time when we think most of that contrast, which we're injecting into a vein, has gone from the arm vein into the superior vena cava, right atrium, right ventricle, out the pulmonary arteries, in through the pulmonary veins, left atrium, left ventricle, and then out the aorta and into the carotid and vertebral arteries of the neck and head. It turns out in people with a normal heart function that we're usually imaging the neck and head about 15, that's 15 seconds, after we give the contrast. So we do that, and here you can see this is the CTA. We can see here's the contrast and vertebral arteries, and we see opacification of these numerous vessels in the right cerebellum in this patient who had a ruptured AVM. This is a different patient. It was in a motor vehicle accident, was ejected from the car and found decerebrate posturing at the scene. We get a head CT without contrast, and here we can see these focal areas of hyperdensity compatible with acute hemorrhages in the frontal lobes. And when we go higher up here, we can see a focal hemorrhage in this nucleus next to the third ventricle. Remember, that's the thalamus, so we have an acute thalamic hemorrhage. We also have some focal hyperdensities in the deep white matter compatible with acute hemorrhages. Notice we don't have a lot of mass effect or midline shift. This pattern of hemorrhage in the bilateral frontal lobes, in the deep gray nuclei, in the deep white matter, and sometimes in the brainstem would be a pattern compatible with a traumatic brain injury and a diffuse axonal injury. This is a different patient. It's a patient that was sitting in his yard talking with some friends and then just didn't feel well, laid down and had a seizure. Got a head CT without contrast, and you can see this large area of hyperdensity centered in the right posterior frontal parietal region. This is compatible with an acute parenchymal hemorrhage. The low density surrounding it is edema. There was no trauma, so we don't think this is a trauma. And with further evaluation, this turned out to be hemorrhagic conversion of an infarct. This patient's 50 years old. So it could have been other things like hemorrhage into a tumor or an AVM, and further evaluation with CTA and MRI answers this question. This would not be a good location for a hypertensive hemorrhage. Let's move on to talking about subdural hemorrhage. So when we see a subdural hemorrhage, that is hemorrhage that's located between the dura and the arachnoid. And you can also get other things besides hemorrhage in the subdural space, such as pus, but we're going to talk about hemorrhage. And remember that that's hemorrhage that's in the subdural space, and it can cross calvareal suture lines, but it cannot cross the midline. So let's look at a case of this. This is a 70-year-old gentleman who presents with left-sided weakness. He gets a head CT without contrast, and here we can see this hyperdense collection. Where is it located? It doesn't look like it's interparenchymal. It looks like it's along the surface of the brain, and if you can imagine, the coronal sutures of the calvarium are about right here. So this is hyperdensity compatible with acute hemorrhage, because we've talked about this before. Acute hemorrhage is hyperdense. It's along the surface of the brain. It crosses suture lines and has this kind of concave appearance, and this would be compatible with an acute subdural hematoma. This subdural hematoma is not going to cross the midline because the falx, this dural reflection, is going to block the subdural hematoma from crossing the midline. Let's talk about epidural hematomas. Those are located between the skull and the dura. That also is most commonly hemorrhage, although other things like pus can be in the subdural space. But this would be hemorrhage that is located between the skull and the dura, but does not cross the calvarial suture lines. And that's because the dura is a multi-layered tissue, and the outer layer is actually attached to the calvarial sutures. So this was a patient that was in a car accident and presented with sleepiness and got a head CT without contrast, and we can see this hyperdense collection compatible with an acute hemorrhage. It's along the surface of the brain, but if you, when you look at the bone windows, this is where the coronal suture is. So it is contained by the calvarial suture, and it has this biconvex morphology or lens-shaped morphology, and this would be compatible with an acute epidural hematoma. Again, these are typically, they're often in the frontal regions because they are often associated or most commonly associated with skull fractures and tearing of the middle meningeal artery. So again, this is that biconvex shape, hyperdense acute hemorrhage contained by the suture line, compatible with an acute epidural hematoma. Let's talk about the subarachnoid space. The subarachnoid space includes all of the CSF spaces. It includes the basal cisterns, the CSF spaces at the base of the brain, the fissures, as well as the sulci along the cerebral convexities. What can happen in the subarachnoid space? Well, you can get hemorrhage, you can get pus, and you can get tumor. We're going to really focus most of our discussion on hemorrhage. So here, if you recall, we talked a little bit about the anatomy a minute ago. This is that basal cistern that is located just above the pituitary gland, the suprasellar cistern. Again, above the cella, that's why it's suprasellar cistern, that feeds into the sylvian cisterns and fissures. And again, here's your middle cerebral artery feeding in here. And this is where the circle of Willis is. So if you have an aneurysm on the circle of Willis, like an anterior communicating artery aneurysm or a posterior communicating artery aneurysm, you're going to get subarachnoid hemorrhage, most commonly in this suprasellar cistern, and then it will spread out into the sylvian fissures, the interhemispheric fissures, and in the cisterns around the brain stem. So this was a gentleman who was watching a football game and cheering, and all of a sudden got the worst headache of his life. He's 32 years old, and you can see here we're at the level of that suprasellar cistern right here, and you can see we have this hyperdense fluid compatible with acute hemorrhage in the suprasellar cistern and extending in the sylvian fissures in the cisterns around the brain stem. And this is acute subarachnoid hemorrhage. Here's some going over here into the right sylvian fissure. So this is what acute subarachnoid hemorrhage looks like. If you see hemorrhage in this location, you've got to think you most likely have a ruptured aneurysm, and you want to look for where that aneurysm is. The non-invasive way we do this is with CT angiography, CTA, and we will do those right after we do the head CT. This is a different patient, but another look to acute subarachnoid hemorrhage. Here we've got hemorrhage in the inner hemispheric fissure. This linear hyperdensity in the sylvian fissures is also subarachnoid hemorrhage because, again, it's in the CSF spaces around the brain. Here we've got hemorrhage in that quadrigeminal plate cistern posterior to the midbrain. This is a 3D reconstruction of our CTA. So when we do CTA, we can real time in 1 minute build this 3D picture, if you will, of the intracranial vasculature. You're looking frontal. This is the two anterocerebral arteries, and this is a lobulated anterior communicating artery aneurysm that was the source of the subarachnoid hemorrhage. Let's move on to talk about hydrocephalus. CT is excellent for hydrocephalus. What is hydrocephalus? It's enlargement of the ventricles. Hydrocephalus can be communicating or non-communicating, also called obstructive. Remember the flow of CSF. You have CSF that's made by the choroid plexus, flows from the lateral ventricles through the foramen of Monro into the third ventricle, from the third ventricle through the cerebral aqueduct to the fourth ventricle, and then it extends out the foramen of Luschka laterally and Magendie medially. CSF then flows around the spinal cord and then back up over the cerebral convexities and is absorbed into the arachnoid granulations. So if you have, say, a fourth ventricular tumor filling the fourth ventricle, you're going to get obstructive or non-communicating hydrocephalus because the CSF made in the lateral and third ventricles can't get out, and so you're going to get enlargement, obviously, of the lateral and third ventricles. Let's say you have meningitis. So in meningitis, you'll have bacteria and white cells in your CSF, and those can kind of gum up the arachnoid granulations that absorb the CSF along the cerebral convexities into the dural venous sinuses. If the arachnoid granulations aren't absorbing well, you can get communicating hydrocephalus. The earliest signs of hydrocephalus is prominence of the temporal horns and rounding of the third ventricle. You will get that first before you get massive enlargement of the lateral ventricle. So it's very important to interrogate the temporal horns in the third ventricle. Here is our subarachnoid hemorrhage patient. If you remember, the gentleman was watching a football game, developed acute subarachnoid hemorrhage, and this person is 30 years old, and if you look, their temporal horns are too big. This is marked enlargement of the temporal horns for a young person. And if you look at the third ventricle, it is not slit, it is rounded. So this person not only has acute subarachnoid hemorrhage, but also has hydrocephalus because the subarachnoid blood is gumming up the absorption of the arachnoid granulations and they're developing hydrocephalus. How about tumor and abscess? Well, often on head CT without contrast, you often can only detect the vasogenic edema that's associated with a tumor or a brain infection such as an abscess. Vasogenic edema is edema that is predominantly involving the white matter. And MRI is going to be our workhorse for then going further and evaluating for tumor or abscess. So this is a 58-year-old patient who comes in complaining of headaches. They get head CT without contrast, and here you can see this low density with associated mass effect. Notice the effacement of the left lateral ventricle. This low density has mass effect, so it's edema. Then we have to decide, is this vasogenic edema or is this cytotoxic edema? Vasogenic edema, remember, is the edema that involves mostly white matter. And if you look here, there's a lot of edema in the white matter, but notice I can see the more hyperdense gray matter very well. We don't have edema in the gray matter. So this would be vasogenic edema. That would tell us we're worried this patient could have an underlying tumor or abscess. And we would then move on to brain MRI with and without contrast to look for tumor or abscess. That's the best next study for further evaluation. And here is that MRI, and this person had multiple enhancing brain lesions with a new diagnosis of metastatic lung cancer. Let's talk about stroke. So we're always going to do a head CT without contrast if we're worried about stroke. And we do that because if someone comes in with new onset weakness or speech difficulties, we have to be worried they could have an acute hemorrhage, and we need to know that right away. But most of the time in acute stroke, the head CT without contrast is normal. And that is because we can't see the edema associated with acute ischemia for about 24 hours, sometimes 24 to 48 hours. It takes time for that edema associated with acute ischemia to form in the brain. And MRI is really the most sensitive study for looking for an acute infarct in stroke patients. Subacute stroke, meaning, patients that have stroke symptoms that started, say, 24 to 48 hours ago, then we can start to see the low-density edema associated with the ischemic brain. And in subacute stroke, we're going to see cytotoxic edema. That is the edema that involves gray and white matter in a vascular distribution, different from that vasogenic edema that mostly involves white matter. You're going to want to look for mass effect associated with the edema and and effacement of the sulci. Old infarcts, old strokes, remote, are usually associated with volume loss, atrophy, because they've lost neurons with the ischemic stroke. So here's a patient that lives alone. Neighbors hadn't seen him for a couple of days, so went in to check on him, found him on the kitchen floor, aphasic with a right hemiplegia. He was brought in, he got this head CT, and here you can see on this head CT without contrast, we've got an area of low density. Notice it involves gray and white matter equally, and notice it is in a vascular distribution of the middle cerebral artery. This would be very classic for cytotoxic edema associated with a left MCA infarct. The fact that we can see it so well means it probably didn't happen 3 hours ago. It's probably 24 to 48 hours old. There is mass effect with this, and a lot of times people say, well, I don't see the mass effect. And that's because in this case, we don't have midline shift, but we do have effacement of the sulci. Notice the sulci on the other side. We don't see any sulci because we have edema and local mass effect. But this is a good example of this cytotoxic edema associated with a relatively recent infarct. This is a patient who also came in, a different patient with stroke symptoms. The head CT without contrast shows this dark area of low density. But notice, instead of having mass effect, we actually have volume loss or atrophy. The Sylvian fissure here is big. The frontal horn, the lateral ventricle is bigger than the other side. And this is what an old infarct will look like. Notice how dark in density this is compared to the subacute infarct. The subacute infarcts are a little more grayer than the old infarcts that tend to be closer in density to CSF. What about MRI? Well, we'll finish talking a little bit about MRI. And again, we can't do all of neuroimaging in a short video, but we'll talk a little bit about this. MRI is not based on, there's no x-ray involved, there's no radiation involved. It is imaging based on the movement of protons in a high-strength magnet. And MRI we like a lot because the resolution is excellent. And not only can we determine, that there's a mass there and there's mass effect, but we can sometimes, by doing different imaging techniques, determine not only is there a mass with vasogenic edema, but we can also tell whether that mass is a tumor or an abscess. And sometimes we can tell what type of tumor we think it likely is by the imaging. Unlike in CT, where we image the patient once, if you remember, we have to do a 5-second head CT acquisition. We take the data and we post-process it to give you different windows and planes of imaging. In MRI, we actually do multiple imaging acquisitions of the brain. So we're going to do different techniques each time we image the brain to give you different information about characteristics of the tissue. And because of that, MRI takes longer to do. So a head CT takes about 5 seconds to acquire, whereas an MRI takes about 30 to 40 minutes to acquire. So in, say, for instance, children, they all have to be sedated, usually with anesthesia, for an MRI. And confused patients sometimes have trouble getting through an MRI because they can't be still for 30 minutes. MRI is very sensitive to motion artifacts. So if someone's moving, it's going to blur the imaging. And some patients can't go into the magnet because they have implants that are that can conduct a current or heat. For example, some spinal cord stimulators can't go into the MRI machine. Again, when we're doing MRI, we're going to do multiple acquisitions of the brain for each scan. And each acquisition we call a sequence, and each sequence has a different name. I'm going to throw through a few of these with you, but over the course of your neurology rotation, you're going to see a lot more, and the neurology residents are awesome at talking about MRI imaging as well. So common sequences I'm going to go through are the T1 sequence with contrast, T2, and the diffusion weighted sequence, also called DWI, with its corresponding ADC map. So remember on CT we talked about tissues being in terms of density. On MRI, we're not going to use the word density, we're going to use the word intensity or signal. So tissues or structures on MRI are going to be hyper-intense or high in signal, meaning they're bright, or hypo-intense or low signal, meaning they're dark. So this is our first sequence. This is T1. How do I know that? Well, I'm first going to go to the CSF, and the CSF is hypo-intense. It's dark. And there are other sequences where CSF is dark, but we're going to focus on the T1. And on T1, we also can do pre and post contrast. How do I know this is pre-contrast? I'll go to the nasal mucosa, to the nose, and the tissue in the nose is the same signal as the brain, so I know we have not given contrast. This is T1 pre-contrast. When I also know that a sequence is T1, not only by the CSF being dark, but also the white matter is brighter in signal than the gray matter. This is how I know it is T1. We really like T1. It's great for anatomic detail. This is T2. T2, the CSF is hyper intense. It's bright. And we like T2 because it's great for showing us edema, demyelinating lesions, inflammation. This is T1. So we know it's T1 because CSF is dark. It's hypointense. We have great anatomic detail. The white matter is brighter than gray matter. And I know we haven't given contrast because the nasal mucosa is not enhancing. When we do post-contrast imaging, and why do we do post-contrast imaging? Because the post-contrast appearance of lesions helps us determine what type of lesion it is. Is it a glioblastoma? Is it an abscess? Is it a meningioma? So this is why we give contrast, and we always image our post-contrast patients with T1 because the contrast agent we use, gadolinium, is bright on T1. So this is a T1, CSF is dark, but I know it's post-contrast because the nasal mucosa is enhancing. Notice the difference. This is a different sequence. CSF is dark, but notice we don't have this nice anatomic detail like we did on the T1. This is the diffusion sequence, or DWI. Remember, you've probably heard this before, but DWI, or diffusion weighted imaging, is just imaging of water macromolecules moving. So if water molecules are moving really rapidly, like they do in water or CSF, we don't have any signal. That's why the CSF is dark. If water molecule movement is restricted or slowed, then we're going to see bright signal on the diffusion sequence. there are certain pathologic entities that restrict diffusion of water molecules. And one of the big ones, and one of the reasons MRI is so important in stroke, is acute infarcts are bright signal. They're on diffusion. And they are also, if you're wondering what is this is what we call the corresponding ADC map, or apparent diffusion coefficient map. In order to say something's bright on diffusion, it's got to be dark on this. So we look on the ADC map. So we look at these two together always. So in this patient, this was an 80-year-old gentleman who came in with sudden onset left-sided weakness. Got a head CT that was normal. There was nothing on it, but he was hemiplegic on the left. Went to MRI, and here the CSF is dark. We know it's not a T1 though, because this isn't this nice anatomic detail of the brain. This is kind of on diffusion, I call it a fuzzy brain. And you can see here on the right, we have this large area of hyperintense signal on the diffusion sequence with corresponding low signal on the ADC map. This would be called a large area of restricted diffusion. It's in the right MCA territory, and this would be compatible with the right MCA acute infarct. There are other pathologic entities that restrict diffusion. One big one that you should know would be the center of a pyogenic bacterial brain abscess. So MRI is really good for differentiating tumor from abscess. So that's another very useful tool for MRI evaluation. So that gives you kind of a starter